female repro, and it's pertinent to both male and female physiology, involves, relatively sort of a synopsis of sexually transmitted diseases, which I am doing now in with micro, which is, as a matter of fact, I finished it. This one I did it all week in micro. So we're going to get a little bit of that. And it is on the exam. I did do the dictation, the review recording. I'm sure you all got it. Whenever you listen to it, you listen to it. We'll go from there. So I did want to acquaint you with that. And lastly, up here, next week, and we'll kind of see how it plays out. I'm gonna pick and choose some topics. This is sort of growth development, and the part I don't like called senescence, which means getting older. I mean, if you're going to talk about, don't look at me like that. Growth and development, and that other word. So I'm going to pick and choose some things that I think are of interest, and I think that you need. You may have had some of it before. A little bit about what goes on with fertilization, and you got to know about the ectoderm, the mesoderm, and the endoderm. If you didn't get that already, but it's a useful review. Where the organs come from, etc. I think all of that's relevant as well. So that is the start of where we're going to finish. We were still finishing, and even though effectively we did finish it, it was the ovarian cycle. And again, the big and really today is the day we look at the comparison of the events that go on throughout female reproductive. And there's one great chart that has 4 little charts that puts it all together that's coming relatively soon. And this is really what triggers ovulation is called a luteal surge. I talked about it in passing. And of course, it's at the end. So what happened? Estrogen levels continue to rise as a result of the follicle. That's what estrogen basically produces. When levels reach a critical high value, this is that oddball, brief positive feedback occurs on the brain. And this triggers what's called the luteal surge, a large spike in the release of luteinizing hormone, when ordinarily you wouldn't expect to see it given the amount of estrogen was there. That's the thing that triggers ovulation. The best way to frame this for you is this: when a couple is having trouble, and I have no idea what they're doing today. This is what you did 46 years ago. Women every morning would take basal body temperature. So they take their temperature, and this is before digital analog thermometers, the old style thermometers. And you just, first thing in the morning, without getting out of bed, and just see when they got up in the morning, what their temperature was. And it was, you didn't have to guesstimate. It all had tiny increments, so you could plot it out in a chart. And you look for a surge in temperature. That basically, typically, was accompanying the luteal surge. And if you're trying to have kids, that would be the time to try to conceive. There's all other different ways we went about doing that. Well, again, unfortunately unsuccessful in that regard, but what do you do? So that triggers ovulation, and as the egg is expressed and ovulated out, then the corpus luteum begins to form. Those high estrogen levels trigger that release of all that stored LH, even some FSH, and that is basically that triggers that primary oocyte just then to go from meiosis 1 to meiosis 2 and effectively be ovulated. And these are the other events. Locally, we see an increase in all of this from that burst of triggering hormones. Local vascular permeability, so the blood vessels more stuff's oozing out of. Inflammatory response weakens that now bulging ovarian wall, and coincidentally, as it bulges, it stops the flow to the protruding wall. It thins as any time blood flow, tissue begins to become damaged and not as strong, and then boom, out comes the ovulation. So shortly after the ovulation, estrogen levels decline. The luteinizing hormone then transforms the follicle into the corpus luteum. And I'm not going to give you a sequence question as to all these sequences. Again, to be very fair, this is not an area that I am. My expertise is more limited in this area, with the exception of knowing what happens when it doesn't work, which I'm very good at with that. So the luteinizing hormone stimulates the corpus luteum to secrete progesterone. Estrogen in the ovarian phase predominates. Progesterone doesn't disappear, but it predominates, neither one. And the progesterone predominates, or is the dominant hormone in the luteal phase. And the whole idea, it maintains what the progesterone does, is it maintains that area we studied before. Remember, the stratum basalis is always there. The functionalis is recycled. It's effectively redevelops, grows, and flourishes, and is shed in the absence of conception with fertilization. And so the progesterone helps to maintain it and maintain the pregnancy and, of course, the rejoinder if it occurs. Negative feedback from rising plasma progesterone and estrogen levels inhibits LH and FSH, inhibin from the corpus luteum and the granulosa cells, enhance it, declining LH ends luteal activity and inhibits follicle development. So all of those things combined are all designed to maintain the pregnancy, assuming there's been implantation, to maintain the functionality of the granulosa cell, to stop another egg from flourishing. And this is what was originally mimicked, and I do not know the pharmacology of today, in birth control pills. This is what I commented on the recording. It's a sophisticated means of, we play biological tricks in pharmacology. And I say we, the medical community plays a lot of biological tricks in pharmacology all the time. I was just talking about my wife's, horrible, another way to say it, poison ivy. She's taking progesterone. She's taking prednisone. It's an anti-inflammatory. We're stopping the inflammatory response, trying to harness the immune response. Okay. I mean, it's artificial, but it gives the body a time to heal. We do this all the time. People go on a keto diet or a low carb diet. You're basically, there's no carbs around, you better gobble up fats. I mean, those are metabolic trips you can do with diet, you can do with medications, all sorts of things. Or basically, and this is no different. The trouble with the birth control pill was the side effects, at least when it was originally constructed and developed. A gal was they're trying to regulate periods. Girl I knew very, very well. And she's coming, and they thought she'd hurt her leg because she's an athlete, she's a cheerleader. Coming in a cast when we were in high school, and they thought this was mechanical cheerleading. And all of a sudden, what's the cast? A new girl in town. And it's always odd because, when you don't start with you like in high school or throughout the school year, it's like you're a whole new different person. She goes, I don't know. I mean, but they put me on this medicine. She goes, they put me on the pill. And all of a sudden, it turned out that they're apparently trying to, I think they're trying to regulate her, and at the same time thought it was musculoskeletal. And all of a sudden, next thing she developed blood clots. The early days, and that really caused a lot of problems. And I know, having spoken with her many, many years ago, 20 years ago, as we were trying to put together a high school reunion. I mean, she had 2 full-grown kids, so thankfully things worked out just fine. So it's very interesting how this plays out. And so, and that was the comment I made to any of you who are going into clinical things, when you're talking to people, or when you ask a question of what meds are you taking, a lot of people don't think, I'm on blood pressure medicine. I'm taking, for women of childbearing age, that's a question you got to ask if you're doing a physical. I mean, I know everybody's going in a medical career. That's a significant medicine. So if no fertilization occurs, the corpus luteum degenerates, the LH levels start to fall, that sharp decrease in estrogen and progesterone, which in turn ends the blockage of the secretions, goes into the cycle to restart, and then it all starts over again. That starts the cycle. Remember, it takes, the oocytes themselves take about 12 months to mature, but the one that's picked for ovulation, we're back to that roughly 14-day period. Okay, which brings us to the uterine cycle or menstrual cycle. So these changes in the endometrium occur in response to again, hormone levels. By definition, they start with day 1 of menstruation. Okay, all the way through day 5. They call it the pre and post ovulatory phases, and this is all about the endometrium. Days 6 through 14, proliferation. Days 15 to 28, it's proliferated, and now we see the increase in the glandular structures secreting a variety of agents that are there for one purpose only, and that is to enable the the fertilized egg to implant. It's the whole ballgame. So the invariant hormones are at their lowest levels. The gonadotropin levels, remember, those are the ones coming from the posterior pituitary and the pituitary are beginning to rise. That function with that absence of progesterone, particularly, remember those spiral arteries we talked about previously in anatomy, they spasm. They're the ones, go back and look at that anatomy. That's at the juncture point roughly between the basalis and the functionalis. That sudden drop in estrogen and particularly progesterone, they cause them to spasm. Why? I have no answer for you. And that spasm causes the layers to detach. The basalis stays, the functionalis sheds. It loosens would be a better word. And as soon, and like any spasm in blood vessels, when it relaxes, the pressure head of blood now take advantage of that now start of separation in tissue and basically separate it. So what menstrual fluid is, unlike what people mistakenly think, is mostly tissue, is mostly water, and it's a tiny amount of blood, more or less speaking. I realize that's under normal circumstances. Obviously, there's irregularities that are there. Remember, it's the old gallon of water, thimbleful of blood, turn it red. Blood's busy in that regard. So by day 5, the growing ovarian follicles start to produce more estrogen, and we're starting all over again. So the rising estrogen levels prompt generation of new functionalis, thickens, glands enlarge, spiral arteries increase, synthesis of progesterone receptors. It's all in this. So in the process that pre-coded into the genetic makeup of these cells is the increased production of progesterone receptors, because that's really where the estrogen gets it started. The progesterone is what causes it to be optimally developed and maintained for the implantation. Thins out normally thick cervical mucus. I mean, that's a little hidden thing when we look at how conception works. The cervical mucus is, and again, the plug reforms so that the baby isn't delivered prematurely, but during this optimal period, that mucus, which could obstruct the passageway, it's just interesting. That's what I like about the next chapter. I don't ask it. It's one I ask very few questions, if any, about. But it's got a lot of interesting stuff that's going on. And it ends at the proliferative phase on day 14. Phase that is the most consistent by far. There's variations of the amount of menstruation in the previous phases, but the endometrium preparing for implantation. So functional layer to be secretory, producing fluid and materials that are likely to make it more likely, to be a better term, to express to express myself in saying that it will both permit implantation and adapt to it, enlarge and secrete, thicken mucus to form the cervical mucus plug, now blocks the entry of more sperm, pathogens, or debris. So we're sealing the chamber for a couple of reasons. Certainly to prevent, a secondary type of quote fertilization, but probably more reasonably to prevent pathogens and debris. So we're trying to set up this sort of pristine, pardon me for expression, pristine container is what I came up with. I mean, it's very, very interesting. We did, when I was at CCAC, and the students just were amazed. They had in one of those big things covered in formaldehyde, a pig's uterus. Oh my God. That was, and every so often you'd find a little piglet. The students would just flip out. We would show them. It's a really neat thing I know we don't have it. They've been probably using the same one at CCAC North since they built the place, which I think was 1990. And so, okay, if there's no, see, I hate it when they say if fertilization does not occur. I think it would be better to say fertilization and implantation or / implantation, because it's really about the implantation, I think. Luteum deteriorates, spiral arteries kink and spasm, cells die, constrict, weaken, pressure head, vessels fragment, and we start all over again. So here are this series of charts that I'll read individually, but you put them together, and they do. And it's really what I think is just like with the heart, that one critical slide that I was so into, and we were talking about lab, same darn deal. Look what happens at the luteal surge. You get a little spike of follicles. They're both there, but minimalize it. Here, look at the surge. Right around that area, you can imagine that onslaught of hormones theoretically associated with that potential, with that temperature elevation, at least maybe a way to graph it. We're into the ovulatory phase. So now we can begin to look at these different phases. So after menstrual phase, we have the proliferative phase and the secretory phase. They're showing what's happening there and what's going on underneath without showing it graphically. And here we have the ovarian phases where we're seeing the images, the follicles being selected, developing, and don't tell them, even though I put it in the dictation. The term I use, and I'll probably give everybody the point on the test. For years, we called it a Graphian follicle for this antral or dominant follicle with the antrum that I talked about last time. In the old days, they called it Graphian. It was a proper name, capital GR, either one A and two Fs or two A's and an F. But when you get to that question on the test, I'll think I'll throw everybody a freebie. I'll expect a small amount of payment for this. Shh, don't tell me. Look, you're only going to have to put up with me for another week in the final. Could you effing laugh at the jokes occasionally? You're new here. It's okay. Everybody else, you're just evil. Remember what the opposite of evil is? Spell backwards, live. Spell sin backward, nice. Sorry, it's an old joke from the 50s. Oh, you were around then? Yes, I was. So look what happens. So we see that ovulation. We can see the expelling of this coinciding with that juncture point where you had the luteal surge and the corpus luteum, and you can see kind of what's happening ovarian-wise. And now we can look at the chemicals that are involved. Estrogen and progesterone, again, in the proliferative phase, it is estrogen-based. The estrogen even increases as it gets to the end of the proliferative phase. But look what happens after ovulation. It's principally progesterone dominant. So it goes from here where it's really very low. Look how much. It doesn't mean estrogen isn't important. It just means progesterone is more important. And then, again, this is that one after the menstrual. This is the separation. You have the basal layer at its lowest, and it gradually starts to increase by increasing the amount of the functionalis layer. Here's the basalis. Now we begin to see the functionalis. We see it. You can see where they've drawn the basalis line, and how it steadily increases. And now, post-ovulation, we get into this. Once you start to see the development here schematically of the glands, the abundance of the spiral arteries, etc., this is really ready for implantation. And hopefully, we'll do the other unit and be able to see really where it anchors here, and it starts the development of the placenta. And really, when that occurs, the signal and how those signals are sent, basically, I have to review to see whether it's produced there or not. That's when we start to see this a very large amount of what's called HCG, human chorionic, and it's probably coming from here, because that's the chorion, human chorionic gonadotropin. Okay, so HCG, that's the stuff that makes the early pregnancy test so reliable. Large amounts produced relatively very early and very accurately statistically, even with these, the one, whatever the dollar kits you can buy, or if you're going to Dollar Tree now, the $1.50 or $1.75 kits. And that's what I mean. You put these images together and take a look at them as I've explained them. They tell you what's going on. So much for that. You got that covered. So this is sort of what I was talking about a little bit with body fat and all of those things. This is where medicine and science. It's the same thing. Medicine, science, chemistry, biology. We can use things for good or use things for bad. Some of the greatest criminal minds were geniuses. It's the go back to Sherlock Holmes and Dr. Moriarty. I mean, you have effectively, as you know, geniuses working opposite. And unfortunately, this is where some of the so people take their understanding of medicine and development and all those things and use them for bad. Sometimes, okay, extremely physical activity can delay it in girls and disrupt the cycle in adult women, can cause amenorrhea, cessation of menstruation. Female athletes with little body fat, adipose cells are needed to convert the adrenal androgens. There's not that many. And in women, remember, they only come from the adrenal cortex. It's the only place where any androgens, testosterone or testosterone-like substances occur. And they play a significant role to estrogens and produce leptin that plays that role in puberty. You have to have this. And that lack of leptin can shoot that down. The androgens play a role in sex drive, particularly in women, in appropriate amounts of red blood cell development. It's really significant. And then, thankfully, it's reversible, barring unusual cases. And even young, healthy women can still see dramatic bone loss like osteoporosis, usually seen in old age. I'll identify a pet peeve. It's parents who are so obsessed over, particularly their daughters, so skinny. It's like, oh, you can't eat that. You shouldn't eat that. It's just that repressive kind of stuff. It's just, there's a fine line between health and trying to let a kid be a kid. That's just a pet peeve with me. I've yelled at my own daughter about it. She was obsessive about it. And this was the great thing. Oh, can you take her this weekend? I've got stuff to do. So my granddaughter, okay, she's not heavy. She's had babies. She gained a little bit of weight before. It's like when she's a little girl, like 10 or 11, the first thing we did is I picked her up. Okay, there's no dad in the picture or anything like that. Right to Giant Eagle. We are on a snackathon. I'm making pizza dough at home. We're making pizzas. They had bulk candy containers and all that. We're having a party. I'm all in on that. I know, bad grandpa. Estrogens. This is promote oogenesis and follicle growth, anabolic effect. We know, female reproductive that. Support rapid, short-lived growth spurts of puberty. Fine. Secondary sexual characteristics, etc., etc., etc. As also maintains low total blood cholesterol. So when this disappears at menopause and thereafter, it's the opposite. Cholesterol levels raise because we're not using it metabolically to make estrogen and estrogen mostly. Calcium uptake. Now you talk about osteoporosis. So if you back that up, you can see what happens. Okay, this is, when we start to look at these kinds of things, they're very, very significant. Progesterone works with estrogen to establish the regulate that uterine cycle, menopause, menstruation, etc., proliferative, etc., all those different phases, changing the cervical mucus, inhibits uterine motility, prepares the breast for lactation, all apropos, again, more active as we think of estrogen in the early phase, preparatory, progesterone in the phase, okay, now we have implantation, and now we have to go into preparation. And you can read through this fairly easily. No different than the male sexual response, pretty straightforward stuff. Variety of stimuli. You can see all the areas that typically engorge with blood, secretions. Again, the same thing. Parasympathetic for the stimulatory aspect of things. Okay, and then sympathetic for the climax or orgasm. That's there. Effectively no refractory period or minimal. Obviously, we all know that orgasm is not essential for conception. It's a little bit different in the male because they don't achieve ejaculation. It's not going there. And again, there's a lots of things they talk about. This is that androgen that's produced that plays such an important role in particular female libido or female sexual drive. It's such a complicated mesh of things, I think. Thus ends that. And I know you guessed it, STDs. You don't have to thank me, it's all part of the service. At least you guys are a couple of years older. Like, with the exception of a couple of students, maybe, one senior student, one ex-mill guy who's older than everybody else. I'm sitting there and telling my wife about the same thing. Here I am, and there are a bunch of, they just got out of high school, and I'm teaching them about STDs. It's getting more awkward because for some reason I'm getting older and they're getting younger. At least you guys are a couple years older. I can only imagine. Watch out when I have to get up here and I got to take the elevator. I got the walker in a few years, and you show up. My God, great grandpa's telling us about sex. See, I got 3 smiles out of that. 4 or 5. Ellie, you got to smile with me. I know. Thank you. God bless. You're usually a good responder. You're too far away. Sorry, Jen is the only one allowed to sleep. It's near the end. I can make fun of everybody. Since Jacob's not here, this is the most fun. So they in this textbook and in this PowerPoint they use STIs. I've been used STDs forever, and then now and when we were kids it was all VDs, venereal disease. Okay, this is scary. If there's one profound statement about this that boggles the mind, in the most highly developed country in the world, why do we have the highest rate? Okay, yeah, condoms have helped. Yes, single most important cause of reproductive disorders. So why, in heaven's name? I don't have an answer. I have a thing that's hard. We are a very provincial society. I know what it was like. Can only imagine, and hopefully it's changed for your age group. I'm not sure. This is as forever with as a kid growing up, my parents would never talk about this. None of my friends' parents would talk about this. Just oh, we don't talk about that at the dinner table. That type of stuff. Where you might ask a question. Don't ask me, ask your father. Don't ask me, ask your mother. And it got to the point where you didn't know who to ask, and all you got was misinformation. Why in countries that are less developed, if you want to think scientifically, medically, but developed in a sense of being as modern in many ways and been around longer than us. Think of Europe. This is discussions that's had in families all the time. They're very open about it. So what happens in my own opinion, there's less erroneous information. They're not learning from other kids on the playground. Oh, you can't get pregnant the first time. Oh, you can't get a disease the first time. We know what kind of false statements. I was going to say bullshit, but I didn't. That stuff is. I use that all the time. Just don't tell the trade secrets. It's all in the shtick. That's me. And the only reason, ladies and gentlemen, why this is significant, because it didn't occur until after HIV. That was the one silver lining in the horrible cloud of HIV/AIDS. So all of a sudden people became much more aware of the potential deadly impact, and I use the term advisedly, deadly impact of sexually transmitted diseases, permanent defects, inability to have children, early hysterectomies, infertilities, ectopic pregnancies, all of the above. because they began to look more into these problems as they became aware of a deadly disease that was passed on by sexual intercourse. And the whole idea is it's foreign. Why historically syphilis, gonorrhea have been around forever. But medicine didn't pay attention to something and really wasn't very knowledgeable about it until the Enlightenment and the post-Pasteur era, part of my micro lecture, as to why a normal biological process that was necessary to conceive should somehow make you diseased or hurt you. You couldn't rationalize it. And then people finally began to get their acts together. But it took until the HIV epidemic to become aware. I will tell this to you in the introductory because I do want to be thorough with this. I think it's appropriate wherever you're going on because I think it's life. But you have no idea what it was like during the time most of us baby boomers who were born between 1945 and 1960, 1951. It was like I graduated high school and said the Summer of Love. It's called 1967. The whole idea for maybe the next 10 to 12 years until all of a sudden they started hearing about this thing, getting more informed about this until the original research was published in 1981. It was the concept was casual sex. No one would, because of the pill, really that was okay. What are you on so we don't get pregnant? That's it. They weren't on anything. It's about the only time people use a condom. Other than that, hey, no. And anyways, the notion was, don't worry, if you get something, the doc will fix you. Nothing could be further. This is it. I mean, there were so many, with him or with her or this. It's beyond belief. I don't know if you guys are familiar with this or not, but if you're not, that's what it was like. And we're not even scratching the surface about this. Just understand. Oh my God. The sermon ends about that. This is the science part of it. The most common bacterial sexually transmitted. This falls into the category. Maybe that's the best way to frame it as well. Of these things. Now they're called drainage. For years we categorized them bacterial, viral, protozoan, major categories. But these are called drainage disorder diseases because its character and the main finding is drainage, either from penis or female genitalia. And the way you identify it by taking a swab or taking an expression of that drainage, and just like you guys did in micro lab, gram staining it, doing the appropriate testing on it, the da. And so for years, gonorrhea was the number one. So I cannot even begin to tell you how many cases we saw in the emergency room that I worked at almost daily, I'd say. After these 2-year periods, I was there almost on a daily basis. Helping my first wife was first assistant head nurse and nursing head nurse. This relatively small inner city hospital, you'd see constantly, 10, 15 cases with gonorrhea or syphilis every day. Also, that was number one. Right now, and that's bacteria. But now chlamydia is number one. Most common bacterial or sexually transmitted. And then the protozoan one, which is a real gem, Trichomonas vaginalis, which is a protozoan. The only good news I can get you for bacteria and bacterial or protozoans is there is treatment. that's very successful. Bad news about it, it's just not immunity based. There's no magical shots you can take or anything like that to get, and that's what what we would do. And we would classify them as gonorrhea or non-gonorrhea. Gonorrheal urethritis or NGU, non-gonorrhea or non-specific urethritis. Gonorrhea for inflammation of the urethra, male or female. And effectively, we treat them all similarly. They do not necessarily work. But the idea was we typically, we come in emergency room in New York City, they fixed me up. So we had to fix them up in such a way, knowing they weren't going to show back up. So here we go again. So, I mean, that's basically was a treatment you gave them. You try to give them all the treatment you could, all the antibiotics you could, generally injecting them with what's called a repository antibiotics. That basically, they're sort of an oil base, and you got 2 big injections in your backside, either side, like golf balls. They felt like that. And then you gave them a medicine called probenecid or Benamid that basically kind of kept it in the urinary tract. Yeah, it's almost like you want to say, see you in 3 months. Because you would. You weren't going to stop. Oh, use a condom, do this, don't do that. Oh, please. Spare me. These were street people, homeless individuals, what we inappropriate, I say inappropriate term, what we now call sex workers. So it's a lot of real life out there. If you're not familiar with that area, those inner city areas, it's best way to express it, it ain't suburbia. So it can be contracted, and this is a real bad problem. This is the reason why all babies, and it's all in the United States, I have no idea worldwide, but I suspect it's the same thing, must have within an hour of birth antibiotic drops in their eyes. We used to use silver nitrate. You guys should remember from chemistry, silver nitrate stuff that you got in your skin, it turned it black. It wasn't permanent, it was like a stain. They used to put that in babies' eyes for gonorrhea back in the day, but the moms and dads would, oh, my new baby has black eyes, what did you do? With reality, it was going to come right off eventually in a day or so. But it's just so scary. Now we have really good antibiotic drops that were there. And that's historically accurate. And the big problem is that blindness, conjunctivitis, permanent eye damage. Chlamydia's name is trachomatis. A trachoma is an eye that looks like it has conjunctivitis, but can potentially get more severe damage. Yes, ma'am.
What if the mom doesn't have that? Is it still recommended that the baby get it? Or?
It's not recommended. It's mandatory. It's not a value judgment. It's just we just do it. It's law. Oh yeah, I mean the biggest problem is not moms who are having appropriate prenatal care. It's just the moms that don't have it, if any, at all. And that shocks people too. What do you mean? It's a telling anecdote. I was teaching CCAC, as I said, yes, this is at least 10, 12 years ago, because I only taught there until 2017. And then as I got older, I just figured I'd stay here. But I was teaching full time here and picking up some extra bucks adjuncting. It's just what I do. This lady, and with the great thing about, what's great about your classes is your age group. What's great about community colleges have non-traditional students. You have people, this gal was trying to become a nurse, who's probably mid-30s. She was, right? She's working at a doctor's office in Fox Chapel. In the spirit of full disclosure, my kids all graduated from Fox Chapel High School. Okay? And I'm telling you this, I'm doing the same thing I'm telling you. And she goes, what do you mean, no prenatal care? Everybody goes for prenatal care. Oh, no. Maybe in Fox Chapel, I'm sure they do. I'm sure they pay a lot of money for it. I mean, we had gals coming in who had gained a lot of weight because they didn't want to tell mom and dad, and they came in crowning. Prenatal care, zero. And a lot of these folks don't want to go to the ER. They're afraid to go to the ER. I wouldn't even talk about, ICE and all that type of stuff. I mean, we don't even want to get into that, Again, when the intersection of politics and medicine is a very bad place to be. Okay. 25 to 50% of all diagnosed cases of PID. PID, if you didn't know, is horrible because the big problem with sexually transmitted diseases, the vast majority, vast is a good term, I'd say minimally 50% and probably 75 to 80% of these are asymptomatic in the female, maybe with the exception of drainage, which doesn't mean it's asymptomatic, but asymptomatic in the sense of severity, pain, all the typical frequency, urgency, burning, urine discoloration. It doesn't have the pain component to suggest, oh my God, something's going on. And they go have an internal pelvic examination when they get to the emergency room or whatever the facility is. And once they start to palpate those tubes, it's like, oh my God, the pain just shoots. It's extraordinary. And at that point, school's kind of out. Now you're a ripe candidate for ectopics. This was all ripe candidate for ectopic pregnancies, for infertility, for early hysterectomies. All horrible. And on the male side, the problem with the male, most of these things, in my opinion, are symptomatic. Guys tend to ignore them. Guys do are not. Women have babies. They're very interested in making sure. Again, Stein's broad brush. They're much more cognizant of and much more responsible vis-a-vis reproductive health. Guys, first of all, their male egos gets in the way. You don't want to go in and show the doc the equipment, and as long as the equipment works, forgive me, everybody. Guys basically they got to have a breakdown before they're going to see anybody. Am I making sense? You're all looking at me going, yeah, I know. That's my opinion. It's right. Between my three kids, we've seen a lot of boyfriends and a lot of girlfriends. And remember what an authority I am about this. No one can speak to you more plainly about understanding sexual behavior in children than a man whose daughter had a baby before she was 16 years of age. How can I offer you all more credibility than that? Whose dad is a doctor and his mom was a nurse. WTF? So all of these symptoms are true for all of them. We're going to get to all of these kinds. That's why it boggles the mind, and that's this notion of being quote fixable. But this chlamydia is really only 20% of the women, 10% of the men have symptoms. That explains it. The drainage is not necessarily. It's easily dismissed. I'm not saying someone should dismiss it, but someone who chooses to could dismiss it. Well, I'm not hurting. It's not. I want the secondary characteristics, etc. Okay, very significant with conjunctivitis. We also have chlamydia pneumonia, and typically we see these with immunological problems. I'll stop it there, and we'll finish this up on Monday. Then we'll be in good shape for everything else because I don't want to have these frightening images in your mind that I'm creating for too long. Now I got to get to work.